This lecture is going to be on lipids. Lipids are not water-soluble, so when they're in blood, they have to be transported within lipoproteins or bound to albumin. Lipoproteins consist of an external phospholipid bilayer that's interspersed with proteins that tell the lipoprotein where to go and what to do. The center of the lipoproteins contain hydrophobic molecules such as cholesterol and triglycerides. Fatty acids can become water-soluble by binding albumin as a transport molecule. Lipoprotein metabolism consists of the exogenous lipid pathway and the endogenous lipid pathway. In the exogenous lipid pathway, fats are acquired from the diet and then packaged into chylomicrons, which are exported into the intestinal lymphatics. These lymphatics converge and empty into the thoracic duct, which then empties the chyle into blood. Within the blood vessels, chylomicrons deliver fatty acids to the tissues, which are either consumed for energy or converted to triglycerides within fats and saved for long-term energy. When the animal has a negative energy balance, these triglycerides can be converted back to fatty acids, which are then exported into blood and then carried to the liver by albumin. The liver is able to synthesize lipoproteins or clear lipoproteins from blood. Within the blood, the lipoprotein delivers fatty acids and cholesterol to the tissues. Lipid metabolism is hormonally regulated. Glucagon and cortisol increase blood lipids, whereas insulin and thyroid hormones decrease blood lipids. This is a list of diseases that cause increases or decreases in blood lipids. Those marked with a star will be covered in this lecture. However, you are responsible for knowing all of the causes listed here, since they were covered in previous lectures or they will be covered in future lectures. Knowing the hormonal regulation of blood lipids is helpful in remembering causes of dyslipidemias, because many of the diseases are due to this hormonal dysregulation. So for example, insulin deficiency or insulin tissue resistance is responsible for hyperlipidemia with pancreatitis, diabetes mellitus, and equine hyperlipidemia. Also, many of the diseases that cause hypercholesterolemia also cause hypertriglyceridemia. So, while this list initially appears daunting, it's not as scary if you combine those disorders into similar processes. Hepatic or posthepatic cholestasis causes hypercholesterolemia by decreasing cholesterol excretion by the liver into the duodenum. Cholestasis also causes increases in bilirubin and GGT and ALP, and if there's hepatocellular injury secondary to cholestasis, you can see increases in ALT, AST, and SDH. Postprandial hyperlipidemia is not seen in large animals, and that's because they tend to ingest low fatty meals, and they are also continuous grazers. In small animals, ingestion of a fatty meal causes increases in all forms of energy, including glucose, cholesterol, and triglycerides. Bile acids and ammonia can also be increased. Hyperadrenocorticism causes increases in glucose, cholesterol, and triglycerides due to cortisol excess. Excessive cortisol can also cause a stress leukogram, hypersegmented neutrophils, and diabetes insipidus. ALP is often markedly increased due to the steroid isoenzyme. ALT and AST may also be increased if there's glycogen accumulation in the liver and a steroid hepatopathy. Urinary tract infections may occur secondary to glucosuria, unconcentrated urine, and immune suppression. The picture on the right shows a functional pituitary adenoma that produced excessive amounts of ACTH, which then caused adrenocortical hyperplasia and excessive cortisol production. Nephrotic syndrome is a severe form of chronic renal failure with significant protein loss. Pathologic renal protein loss causes marked hypoalbuminemia, decreased onconic pressure, and clinical signs of edema or ascites. In an attempt to increase albumin production, the liver enters a hypermetabolic state, and in this hypermetabolic state, it increases production of other substances in addition to albumin, and this cause includes increased production of cholesterol and triglycerides. A protein-losing enteropathy is when intestinal protein loss causes decreased protein concentrations in blood. Often there is loss of albumin and globulins together, resulting in panhypoproteinemia, but less frequently you can have albumin loss without globulins. Concurrent clinicopathologic findings are variable, but may include those of gastrointestinal hemorrhage, such as regenerative anemia and an increased BUN relative to creatinine. Also, there may be hypocalcemia due to decreased intestinal absorption of calcium. There may be electrolyte loss and therefore hyponatremia, hypokalemia, and hypochloridemia. And if there's lymphangiectasia, such as that pictured here, then there can be loss of lymph, which includes loss of lymphocytes and loss of cholesterol. In this picture on the right, there's the serosal surface of an intestine, and those dilated lymphatics are causing these little blebs, these little vesicles, and this is called lymphangiectasia. The serum cobalamin may be decreased if there's ileal disease, and serum folate may be decreased if there's duodenal disease. Equine hyperlipemia most commonly occurs in ponies, miniature horses, and donkeys. The inciting cause is any cause of insulin resistance. So this includes states of fasting, physical inactivity, stress, or systemic inflammation. This insulin resistance results in mobilization of fatty acids from adipocytes. The liver then converts these fatty acids to lipoproteins, which then delivers fatty acids to various tissues. Excessive amounts of fats deposit in the tissues, especially the liver, the kidney, and the muscles, and this results in tissue injury, tissue dysfunction, and organ insufficiency. These animals often develop hepatic lipidosis and renal lipidosis. Accumulation of these fats within cells actually worsens the insulin resistance, and this starts the process all over again.